of go follow them through. Then you have a patient, you put them on antihypertensives and you put them on 3 or more and they're still not controlled. Think about these. How do we remember these? Remember, it's a little bit out of order, but renals, okay? I know it's a funky one, but renals. This is going to be by far the most common cause of secondary hypertension is renal disease. So when patients have renal vascular disease, the concept is pretty straightforward. Maybe their disease process is something like chronic kidney disease, or maybe they have something like renal artery stenosis. Either way, regardless of the cause, when the kidneys have some type of process where they are damaged, they frick up the actual GFR. They mess up the GFR. And when they do that, it leads to an increase in the renin-angiotensin-aldosterone system. And these things get jacked up. And you know what these do? We don't need to go through the whole mechanism. We should already know this from like our basic physiology, is that angiotensin 2 will lead to a lot of aldosterone, ADH, sodium, water retention, vasoconstrictive mechanisms, which do what to your blood pressure? Shoot the blood pressure up. And that's what happens to these particular patients. All right, so I want you to think about that. So if you have a patient who has underlying chronic kidney disease, or you're auscultating their abdomen, you feel like a weird bruit, think about renal artery stenosis, think about CKD, or a renal vascular cause of their high blood pressure. Okay, next one is endocrine. Endocrine is an interesting one. And whenever we think about endocrine, I think two particular organs, the thyroid and the adrenal gland, right? Thyroid's funky, and it kind of makes it easy to remember, but it can be both. Whenever you got thyroid, if it's too high, T3 and T4, or too low, both of these can cause hypertension. You're like, wait, what? This is weird, man. If you got high T3, T4, you gotta stop eating thyroid. I'm just kidding, all right? But when you think about high thyroid levels, what this does is it causes your cardiac output to go up. It causes the heart to beat harder and beat faster. And so that will push your systolic blood pressure up. And so what happens with these is they increase cardiac output, which increases your systolic blood pressure. So you're gonna have an increase in cardiac output and an increase in your systolic blood pressure. We call this systolic hypertension. So the top number is going to be super high. For whenever you have low T3 and T4, hypothyroidism, this normally controls your vessel tone. So it tries to play a role in kind of causing the vessels to dilate a little bit. But if you have very low levels, what do they start doing? Constricting. When they constrict, it increases your systemic vascular resistance, which increases your diastolic blood pressure. So the funky thing to remember about these is that this will cause diastolic hypertension, the bottom number, to be a lot higher. And that's the weird thing about these. All right, all of these, I'm not going to go through all of their mechanisms because we'll talk about them more in endocrine, but the adrenal gland, literally every possible hormone that you make here can cause this problem. So usually it's due to high aldosterone, high cortisol, or high amounts of epinephrine and norepinephrine. So if you have high aldosterone levels, this is called hyperaldosteronism. This will increase sodium and water retention. Cortisol, whenever you have very high cortisol levels, what do we call this one? Cushing's syndrome or Cushing's disease. This will cause increased sympathetic activity. And then increased norepinephrine and epinephrine, when these are higher, it's called pheochromocytoma. And all of these things will work through various mechanisms that I don't want to kind of bog us down in, but they will work to increase your blood pressure. And so that's something I want you guys to be able to think about here. All right, so let's quick recap again. What are the causes of the endocrine problems that lead to secondary hypertension? It could be thyroid disorders, it could be hyperaldosteronism, it could be Cushing's syndrome, or it could be a pheochromocytoma. Let's write those down. All right, guys, so that is going to cover all of these parts for the endocrine disorders. Now let's come down to the neurological disorders. So it's actually pretty straightforward. So with the neurological diseases, it usually has to be some type of like neurologic catastrophe usually. Anything that increases the intracranial pressure, whether it's a bleed, whether it's edema, whether it's in cerebrospinal fluid, whatever it may be, a tumor, anything that massively increases the intracranial pressure inside of the brain will lead to something called Cushing's triad. So this is something that they can definitely kind of mess with you on the exam. If you have a patient with underlying like altered mental status or neurological deficits, and they present with these particular findings. One is bradycardia, one is high blood pressure, and the other one is irregular.
Imagine choosing from 100 plus meals a week that are healthy and also delicious. Let's be real, Factor's menu is way healthier than the competition. Their chefs actually know what
respirations. This should key you off to really think about some kind of problem here that's leading to this. So again, it would be Cushing's triad, such as low heart rate, high blood pressure, and irregular respirations. This is definitely a classic finding for someone having these particular findings. So they have super high blood pressure, a low heart rate, irregular respirations, and neurological deficits. That could be the cause of their secondary hypertension. All right, the next one. You really want to think about this one, aortic diseases. You want to think about something called a coarctation of the aorta. So coarctation of the aorta. This is usually going to be something in very young individuals that you kind of see this in. But you see how it's a narrowing of the actual aortic lumen? Usually this comes after the left subclavian artery. And so what happens is it narrows, and then all this kind of like, look at this. You see how blood is supposed to be moving here, right? It's supposed to go from the left ventricle, it's supposed to go into the aorta, and now all this has to squeeze through this tiny little lumen now. All the pressure proximal to that little constriction point is going to be crazy high. So what you'll notice in these guys is that they will have an insanely high upper extremity blood pressure, right? They will have a very high upper extremity blood pressure because all of this is going to be super high in all the vessels proximal to this kind of like narrowing. So all the vessels going off to your arms are going to be super high blood pressures. But then you have very little blood going to the distal part here. And so what you'll notice is you'll notice a very low lower extremity blood pressure. And this is something that you definitely want to be thinking about as a potential cause. So if you see someone has like cyanosis of their lower extremities, they have low lower extremity blood pressures, high upper extremity blood pressures, think about coarctation of the aorta. All right, the last one here. This is actually super interesting. We're gonna have to bring this guy over here a little bit. But this is gonna be little people, just to finish this kind of like mnemonic a little bit. So this is little people. And this is really particularly for people who have what's called preeclampsia or eclampsia. So we're gonna put here, this is gonna be something like preeclampsia. Now, preeclampsia is usually, there's a patient who is usually in their like third trimester, around that time frame, and they have a lot of proteinuria, they have a lot of edema, and they have a lot of high blood pressure. So whenever you see these kinds of findings such as edema, proteinuria, and hypertension in a patient who is pregnant, you want to start thinking about, could this be preeclampsia? Because if they start seizing, then you know they have what's called an eclampsia. That's the only really difference between preeclampsia and eclampsia is seizures. So look for this, and the reason behind this is super kind of interesting, where they think that what happens is the baby is getting insufficient blood supply, and so what happens is the placental vessels start releasing chemicals. Whatever these vasoactive chemicals are, we don't really know, but these vasoactive chemicals, what they do is they cause vasoconstriction. So what they try to do is they really try to amp up the blood pressure. And whenever they amp up the blood pressure by really vasoconstricting, it's hopefully going to perfuse these placental vessels more and perfuse the baby. So it's an unfortunate kind of response that increases the maternal blood pressure and can lead to a lot of complications. But definitely something to think about in a patient who is pregnant. All right, we come to these last two to finish off the renals mnemonic. Now, substances. You always want to be thinking about this. If you have a patient with an altered mental status or they have some type of like weird activity, like they're diaphoretic, hypertensive, tachycardic, and they have a history of drug abuse, look for things that really, like, generally, what they do is they amp up your sympathetic nervous system. Any kind of drug that really does that will definitely kind of like pump up the blood pressure. So if you have increased sympathetic medications, we call them sympathomimetics, that would definitely be one. What would be a potential drug that could do that? Cocaine would be one. and amphetamines. These are definitely going to be your big hitters that will cause this type of effect here. So think about amphetamines and think about cocaine or even like PCP. These things will increase the sympathetic nervous system and increase your blood pressure. The last one here is sleep apnea. Believe it or not, this happens to be a big one. This is really becoming a very prominent one. What happens is patients who have sleep apnea, they have periods of apnea. And during those periods of apnea, they don't properly oxygenate. So they develop very low oxygen levels during their sleep process. When you develop low oxygen levels, what it does is it activates your sympathetic nervous system. And whenever you increase your sympathetic nervous system, it's hopefully trying to get more blood flow to the lungs and get better perfusion to the lungs. But unfortunately, what it does is it clamps down on your systemic vessels. And these patients develop pretty high refractory blood pressure. So you want to think about this usually as a potential cause. If you have a patient who is obese, if you have a patient who has maybe a lot of somnolence, they snore a lot at night, maybe witnessed by their partner, and they have high blood pressure, think about sleep apnea related secondary hypertension. All right, that covers secondary hypertension, right? So now what I need us to do is, we have a patient who has either essential or secondary. Secondary refractory to 3 or more antihypertensives. Essentially, usually these are the features, and they're usually 55 years of age and they have a family history. When these patients come in, you have to think about, okay, we've talked a lot about high blood pressure here as the cause of this disease. What is truly high?
Stabbing your face with needles. Sounds terrifying, but here's the reason why you may want to do this. This is cured.
Well, when you look at this, normal blood pressure should be adequately less than 120 systolic and less than 80 diastolic. As they start getting their BP a little bit higher, maybe it's in between, it's greater than 120, but it's at least less than 130. Now we're at pre-hypertensive. Then we get to the patient who's stage 1. Their blood pressure is still a little bit high. We don't really like this. It's greater than 130, but it's at least less than 140. And in this particular situation, it's greater than 80, but it's at least less than 90. Then we get to the stage 2. This is a patient who's usually not very good. We don't like this. They are greater than 140, and they are greater than 90. This is usually where we get a little bit concerned when we see this for at least 2 or more readings. If we see this number for 2 or more readings, this is truly what we would consider to be, hey, this patient needs antihypertensives. Stage 1, if you're at that point and you have other comorbidities and a lot of risk factors, you could start medications. But what we really get concerned is when patients get their blood pressure up to greater than 180 systolic or greater than 120 diastolic. But there's 2 terminologies that we have to understand, and we'll go into more detail next. Hypertensive urgency is when this has a high blood pressure. Hypertensive emergency has this high blood pressure. So what differentiates them? Do they have target organ damage? I'm going to say that again. Hypertensive urgency is no target organ damage. Hypertensive emergency is target organ damage, but they both can have this high blood pressure. That is super important. All right, we've covered the pathophys of all of this. Now what I want to do is I want to say, why is hypertension bad? What are the complications? All right, my friends, so now we're going to talk about the target organ damage. So if the patient has hypertensive urgency versus emergency, systolic greater than 180 or diastolic greater than 120, and if they have target organ damage, it's an emergency. If they do not have target organ damage, it's an urgency. Now, patients who have target organ damage is usually going to come in a couple different flavors. One is cardiovascular disease, neurological disease, renal disease, and retinal disease. These are the common features of injury and complications from high blood pressure. One of these is when patients have chronically high blood pressure,